Okay. So thank you guys so much for coming. This is the National Care Coordination Academy's first open office hours. It will be led by Jess, formerly known as Jess Bellevue, but now Jess Genova. Congrats on getting married recently.
Thank you.
If everyone could just mute themselves, please, just so we can make sure that we hear Jess's presentation. We will not be offering continuing education credits for this session today. It's sort of meant to be a little informal. Of course, we're always a little formal with doing a presentation. We can't get away from slides, but we'll do just a couple of slides up front in the beginning to help frame the conversation. And then we'll leave it really open to, I want people to feel comfortable to unmute, talk with each other, ask questions. We will have Jeff and Rich Antonelli will also be on the call to help answer some questions. And really meant to just learn from each other and see where you're at in your current data collection and see where we can get you going forward. This session will map nicely to the past Academy session we just did and also to the next one that's coming on July 26th as we work towards building out, as we call it, your Mother's Day card or your 1 to 2 pager work plan and presentation. So we'll start to talking about how to analyze the data today, but then when we get to the July 26th session, we'll talk more about now you have the data analyzed, how do you then put it meaningfully and really narrow it down on a 1 to 2 pager. So I will kick things off over to Jess and we can get started.
Awesome. Thank you so much, Heather. Hi, everyone. It's nice that I get the chance to connect with you all again. I think it's been about 8 to 10 months since I last came to the group, and I'm excited to hear the questions that you have around implementation and data analysis, and just to see where you all are at with that as you all have come so far. So let me just get going. I have no conflicts to disclose. So to frame this open office hour session, I did want to do an overview of PICS and CCMT. It's going to be very brief. I know that you all have been working with the tools over the last few months and getting comfortable with them and adapting them to your own setting. So it'll be very brief. The majority of my quick little intro will be on translating the PICS and CCMT data into shareable results. And then at the end, we'll keep the office hour open and just have an open discussion with time for questions and answers. And before I start, I want to reintroduce myself. I am Jessica Genova now. I am the manager of the National Center for Care Coordination Technical Assistance, and I'm a faculty member for the Care Coordination Academy. So zeroing in, we wanted to focus today on 2 of the tools in the National Center Toolkit that you all have been working on adapting and implementing in your settings. That is the Lucille Packard Foundation for Children's Health funded the Pediatric Integrated Care Survey, or the PICS, and the Care Coordination Measurement Tool. So as you all know, the PICS is a family experience measure of care integration. It's considered an outcome measure. It includes 19 validated experience questions and healthcare status and utilization questions, as well as demographic questions. It's available in both English and Spanish, and then there's also different supplementary and topic-specific modules that you can add on. The core instrument has 48 questions, 30 of them are validated for ranking. These are the modules. Again, this is just an overview of the PICS to orient us to the questions that you might bring into the conversation. I did want to focus for a minute on how folks typically share the results that they get from PICS implementation and receiving data from using the PICS tool. So a few key points. One is that if you can report a change in PICS scores from, say, a baseline measurement to the next round of measurement across any key questions that you feel like your stakeholders would be most interested in, or that your stakeholders have identified they are most interested in, you can use those 2 measurement points to report a change. So like the delta, the difference between the patient and family responses across those key questions. And that's pretty simplistic, but it's a powerful tool because it measuring at 2 different time points gives you the opportunity to say, at baseline, we were this, and then it went up by this percent on a certain question. And it's pretty powerful to show that. So you need obviously 2 measurement points to report the change. And one example of a question that you could pull out to report the change is, how often has your child's care team members in the example clinic treated you as a full partner in the care of your child? Also, another best practice that we've seen in other groups that we would recommend is sharing any changes in the validated questions, especially if your stakeholders have a particular interest in kind of the research side of the PICS survey and how there are validated questions embedded in the instrument. You might want to pull out those specific validated questions just to showcase, for example, in your Mother's Day card or your 1 to 2 pager. Also, for the PICS.
Can I ask a question, Jessica? So I've got all the PICS stuff somewhere on my computer. Does it indicate which ones are validated for research purposes? I kind of think it does. It's those main constructs.
Yes, there are 19 validated questions, and they're call out in the PICS user guide. I can circulate that after the call as well, just so everyone has it. But yes, they're called out there. Good question. And then a few other best practices in sharing the results from the PICS include really using the responses as a way to give the report or whatever you're disseminating some color and to emphasize key points. Other groups have called out key questions in a text bubble, kind of bolded it, emphasized it, because a lot of these questions around care integration and family experience of coordinated care, those questions aren't typically asked. And so it's nice for your stakeholders to see that they are being asked and families are reporting responses to them. I am going to move forward to the CCMT tool, but I wanted to pause. I know we're going to have some time at the end of the session to answer a variety of different questions on PICS and CCMT, but anything in particular here that folks want to ask quickly?
I'm just curious, is anyone actively using the PICS that's on this call? Has anyone done at least the first part of doing it before your intervention or your care coordination implementation efforts?
So in Minnesota, we're going to use a combination of the PICS and the FECC. We kind of took questions from both. Personally, I really like the PICS, and we've used it in a few of our clinics. But that was probably 3-4 years ago. But the FECC also had some more operational type questions that our care coordinators really wanted to get parent feedback on. So it was kind of like, so when we have the final, we're kind of, we're like at version 1. When we get the final, I'll send it to you guys.
That'd be great. Yeah, we'd love to circulate it. Yeah. So you're combining the FECC with the PICS and kind of making your own questionnaire.
Yeah.
Okay. And you plan to administer it soon to your patients and families, and then you'd re-administer it, 6 months later or so?
Yep.
That's great. Yeah, we'd love to see it.
I would love to see that and how you're able to kind of marry both sets of questions. Yeah, that's a great idea.
Because the way we kind of picked our questions, we aligned them with the new national standards that came out, and it was interesting. So even though those just came out, the PICS really aligned nicely with most of them.
Yes, I feel like the PICS has always been ahead of the game a little bit, and now everyone's sort of catching on.
Great.
Is anyone else using the PICS or any other sort of patient and family experience questionnaire?
We've been using the one in Indiana from as part of the 10-state CoIIN. And so since we already have increased scores on that, we're going to just continue to use that interval since we have prior comparators.
That's excellent. Yeah, to stick, if you already have one that you're going with, to stick with that, to keep comparing. That's wonderful.
Mhm.
Anyone else? Great. All right, maybe we can move on to CCMT and then we can dive into more questions about PICS after.
Great. Okay, so transitioning to another tool in the National Center toolkit is the care coordination measurement tool. So this tool is used to track care coordination activities that occur in the non-billable, typically non-face-to-face encounters that providers, nurses, care coordinators, social workers have in the space between billable clinical encounters. And as we all know, a lot of the work of care coordination occurs in that time. And it's, like I said, not billable, so it's sometimes challenging to track that. So the care coordination measurement tool is a way to capture the value of those activities. It supports efforts across all disciplines in doing care coordination, and the tool allows you to identify gaps and redundancies in care. So this is the tool. I'm sure you all are very comfortable with it and aware of it. There are different domains, patient level characteristics to capture demographics, care coordination needs, activities that were done to fulfill those needs, outcomes that occurred as a result of the care coordination performed in the billable or the non-billable kind of space between encounters, the outcomes that may have been prevented, such as an emergency room visit or doctor's outpatient appointment that may not have needed to happen. And then what was the time spent on those care coordination activities and what staff performed them, and was that staff member performing at the top of their license, or was clinical competence required to perform that care coordination activity, or can, and I'll get to this, or could those activities be task shifted to someone who does not require, who doesn't have clinical competence to do that. So these are typically the steps in adapting and implementing the CCMT. I've highlighted in the orange box where I think, or I guess you all might be at this point in your journey with the Care Coordination Academy. So I know that many of you have started to develop a tool and test the tool using different use cases and do inter-rater reliability. I've met with a couple groups doing that. And now likely you're kind of at the point where you may have some CCMT data or other experiential data, and you're trying to move that into a way that you can share those results with leadership or your stakeholders. So certain best practices that I would share with you on sharing the results from the CCMT data capture that's performed is to think creatively about different data visualization techniques that you can use to share your story. Many groups use pie charts and bar charts to share the story of the care coordination activities performed, the time spent. So I think and Heather, you can speak to this as well because you have been involved in CCMT projects and have done a lot of this. But one example is the data that you collect around the time spent of your staff performing non-billable care coordination activities is usually displayed in like a pie chart, like of their time overall spending on care coordination. How much time did each activity take? Was it 1 to 5 minutes, 5 to 20 minutes, more than 20 minutes per care coordination encounter? And Heather, I don't know if you want to jump in on that too.
Yeah, no, definitely. So we used pie charts and bar graphs, and we were showing like Jess said, how much time it was taking the care coordination efforts, one person, like how much we could look at it in a patient perspective too. The patient took 50% of an RN's time, another 25% of a social worker's time, another 10% of an administrative, and all of these were non-billable tasks at the end of the day. So that was an example that we've done. We've also showed outcomes prevented. So out of this one care coordination task that was performed, whether it was scheduled an ED follow-up visit or helped the family make sure that they had access to the medical supplies or access to food, or help the family, establish a secure housing by housing shelter, whatever that care coordination task was. We were able to also show how many outcomes that prevented. And again, that outcome prevented area, it is sort of up to interpretation, but by providing that family with, assisting with stable housing, it's possible that we reduced an ED visit, we reduced stress to the family, we reduced, burden, we reduced the patient getting, more sick because they weren't in a safe environment. So you're able to kind of show all of those outlined and do some nice graphs with that.
Great.
Heather, this is Rhonda. Having used like a derivative of the CCMT at many different places, the hardest thing for people to identify is what was prevented because it didn't happen. It's so intense, and that I've had nurse practitioners struggle with that, providers, nurses, that honestly, with what we're going to use, I'm going to leave it out for this time, just because it's really hard to quantify that. And they weren't, the biggest thing was they weren't comfortable doing that. Well, I don't know that I prevented it because it didn't happen. I mean, well,
yeah, it's a weird thing.
It's kind of an oxymoron, but it's just, it's really hard for people that, and I don't know if you have any tips on how to like help people identify those prevented outcomes and feel comfortable doing it. I think that's
yeah, so I think the first thing is just being completely honest that you cannot 100% say because of what you did, you prevented this because because it didn't happen exactly. So you can't measure something necessarily that didn't happen. But the way I looked at it, and when I was training staff that I was working with is, for example, if I'm on the phone with a mother and she says she was about to go to the ED, but she's not going to go now because we were able to get a refill urgently on albuterol, and she feels stable at home because she just talked to me. I talked with the provider. We have a clear plan in place now where she's going to give albuterol around the clock for 24 hours and then go to the ED. That type of care coordination encounter that just happened. The mother told me she was going to go to the ED. I got a message that says mom is calling. She's worried about so-and-so. They're thinking about going to the ED. But because they were able to have that encounter, which I would consider it care coordination, I was able to talk with a provider. This is when I had been RN of complex care coordination. Because that encounter happened, I'm just sort of saying now that, likely it prevented an ED visit. We were able to coordinate, we got her the medication, we made a clear plan, and now she feels safe to not go to the ED. But there's other ways of another one that's on the outcomes prevented that I used a lot was unnecessary family burden and stress. And so by doing these care coordination tasks, whether it's completing a prior authorization, it's helping a family get connected to different food resources, anything really, it's helping the family. So an outcome prevented is this mom is now less stressed. Do I know 100%? I can tell she's less stressed. And again, it is really like subjective. And that can be hard. It's not clear research that 100% I prevented this, but it's really about like those anecdotal experiences and just sort of thinking like, because I did this, I'm pretty confident that I made this mom feel that she didn't need to go to the ED or that she feels like she is, comfortable with taking care of her child tonight because I took the time to explain, what they meant at the ED visit or something like that. That's kind of how I frame it. But I know it can be very provider specific in what they feel comfortable with, but I do feel like it's one of the more powerful areas on the CCMT that there's really no tool out there that I've seen that does that. And it's probably because of that uncomfortable area of how do you truly know you prevented that? Rich, would you add anything else? I think you're out there.
Well, I put a couple things in the chat, but I'll and then I think we capture the chat. But Rhonda, that's actually the reason why, if the team decides they want to measure anything that is preventable, and the more clinically oriented your team is, we really recommend this. So, we had a huge diversion from the emergency department for kids with seizures when we gave them urgent access to a nurse practitioner ambulatory clinic. saved a ton of money. And similarly for our enteral tube or our G-tube population. So the more medically complicated patients, put together 1 or 2 vignettes, sit everybody down, then you do the inter-rater reliability. And as Heather said, if an RN and NP spends 20 minutes on the line with a parent, whether it's a video call or a telephone encounter, let's say because there's a redness at the gastrostomy insertion site, and the mom says, thanks, this is great. Well, guess what? Mom, probably if you hadn't done that, would have gone off to the ED. So that's number 1. Number 2, and I put this also in the chat, it's absolutely fine if you choose not to tackle what was prevented. But that means, especially for payers, and we're trying to create a value stream. So if that care coordination encounter led to a creation of a plan of care, a refinement of a plan of care, clarified a rec question, et cetera. So and in all of our CCMT work, we have found that anywhere between 7 and 12% of all encounters actually identified a discrepancy in information, med dosing, order by which imaging studies and clinics relate, who's responsible, et cetera. So don't feel obligated to do the prevention piece, but if you're dealing with populations of complex kids and you've got clinicians doing the encounter, it's pretty important to be able to do that work. And ultimately, the goal here is not to say, gee, 30% of the complex care service at Gillette Children's diverted from the ED, because any Medicaid director or Medicaid medical director, or for that matter, the CEO of Gillette Children's is going to say, well, the literature for that is for kids with medical complexity. It's a sine wave, right? You might have just hit them on the low side of the sine wave. So that's okay. But ultimately, what you folks are trying to do is to demonstrate to your institutional leadership, your regional delivery system, or your Medicaid agency, these are the activities of care coordination. This is how they align to equitable outcomes, reduction in harm, et cetera, et cetera. Okay?
Yes. Oh, thank you. And
Yep.
so one thing that we're gonna tackle with the CCMT, and I don't know if any other organization has done this, we're gonna have parents also use it to identify what families are doing for care coordination, because they carry a heavy load. And I'm more just curious if anybody has attempted that, any pearls of wisdom that you might have.
Well, on my end of the National Center, I haven't been part of a project where families have used the CCMT, though I defer to Rich, I think, in this scenario with your years of experience.
Yeah, I think my strategic answer is to what end? So in fact, National Family Voices, when we first invented the CCMT many years ago, was literally one of the first stakeholder groups that came and said, gee, we'd like to do some work. And in particular, at that time, it was the Washington State team. So to the extent that families want to document what they are doing, we're all for that. But through the lens of the Care Coordination Academy, what does that data mean? Maybe that data means that families' time should be valued in a delivery system. Maybe that means that, holy cow, families are preventing a whole lot of low value care. They need some resources to be able to do that. So one of the entities that I am aware of, and I think Heather might have done some of this work when she was in the adolescent program here, is telephone rounds. So those high risk kids, every Friday afternoon, i.e. before the weekend, all right, did the formula get delivered to the doorstep? Did you get that new anti-epileptic that the neurologist prescribed? Any questions about that? So the shift is really, really important. So totally appropriate for families to use the CCMT, but because we want to honor any contributions they can make to this overall cause, Ask that question. And what's the goal of that?
Okay. Any other questions related to sharing the results from CCMT? Just
Yeah,
based
hi
on
Jessica.
your-
I was trying to unmute myself.
Hi, Annie.
It's Annie from Chalk in California. So we kind of have this same issue that you in Minnesota were talking about with people being a little bit timid in declaring that they prevented something. So when we did our initial, even before the validation, when we were trying to figure out what questions we wanted to make it specific to our hospital system, we asked everybody what they thought should be included. And there were a lot of things that were added. I can't even remember, to be honest, which ones were on the original CCMT versus what we added, because we added quite a bit. We kept a lot of the core elements, and then we did it in REDCap. So we had like subsets, so like you could click on something or hover over something and get like more specific answers underneath. And a lot of people picked things like, or asked to have included things like continued stress or financial barriers or delays in care. So it wasn't quite so specific. And in the end, now that we're looking at our data, we're kind of like, oh, I wish more people would have picked like avoid the ER or admission, but at least we have something rather than nothing. So that's kind of how we dealt with that problem. I don't know if it was the best way, but that was our compromise.
I appreciate that comment, Annie, and thanks for describing a bit about your team's experience taking the tool and the format and then bringing it into your own setting. I would love to see it. I think we connected a couple months ago when you were all starting out, so would love to see that.
Yeah,
And
no, you were super helpful. Thank you.
you make a great point too with, you know, at the beginning and in developing the tool and kind of adapting it for your setting, you want to add more in. And then when it comes to looking at the data, at what you captured, and thinking about how to share that with your stakeholders or your leadership, some things become relevant and other things don't. And there's also stuff in the middle where you think, okay, maybe in some scenarios or some presentations you'd want to share that, but leave it out of others. So yeah, I don't know. I think it's a very interesting experience.
I just wanted to add one thing too, that I liked what Annie said too about some of the broad categories. I found that a little helpful too when trying to present some of the data, because if you have like 4 outcomes prevented or even any of the categories, a ton of all different options, and then everyone's putting their data in and choosing all these different options. When you go to look at a graph of it, it might be like 3% here, 10% there, 9% there, and you see there's so many different options. So it can be a little challenging to narrow it down, but if you do have some broader categories of things that you really want to showcase that your team is doing, that can be a nice way of showing like, here's 4 things that we, you know, are really focusing on, and you can see the data that way rather than all of the different tasks that we know we're all out there doing. But you might want to focus on some of the real important ones that you want to showcase to your leadership or to Medicaid, whichever you're trying to go after for more funding sustainability.
Yeah, one of our nurses is really a great informaticist. She wouldn't say that, but I would. And she, in our pilot phase, suggested really narrowing in on the other. We had other for almost every one. And then we calculated all the others and included them in the actual data, our 5-week, like real-time data, not the pilot, after the pilot. So we were able to kind of group things a little bit. And even after looking at the data now, there's quite a bit of others still, but we feel like we can legitimately put it in a category so that we can properly categorize it without, you know, taking away the intention of the person who filled it out.
Yeah, no, that's great. I had a similar experience when I first started with my team. When we started implementing the tool, when we built it, we thought, oh, these are all the categories. This is all the stuff we do. And then when we started using it, we were also doing the same. It was like other. And then we talked together and we realized we were able to include our other categories into our CCMT as options because they became so common. It was, you know, other was selected, but it was other, and it was 10 of the same things that we're putting in there. So we were adapting the CCMT a little bit in the beginning until it fit really what our team was doing. And then we were able to productively collect more data. Awesome.
Great. So I'll just kind of finish out these slides and then we can open it up. So it seems like from conversations I've had with other Academy faculty members that most of you are at the point where you have some raw data that you are analyzing now and are moving into the interpretation and dissemination stage. I believe that in the session in July, you all are going to dig into a bit more distilling the data and the results that you have gained from the CCMT and PICS into the Mother's Day card. So that's all to say that framing for this session, the next hour can include questions around, well, how do I put this into the Mother's Day card, or they can be as tactical as how do I use the PICS user guide and how do I analyze CCMT data, for example. So we'll kind of just move into an open discussion now. I'm going to stop screen share, but please feel free to ask any questions or make comments, and we are available.
Yeah, I have a question. I just wanted to ask you guys, I'm not sure, Jessica, you were involved in the cardiology outpatient paper or not? I'm not sure. The one at Boston Children's that used the CCMT? I'm not sure.
That was a little before my time at Boston.
Okay. Well, so maybe it's a question for Rich, or maybe, I don't know. But just moving from having all the data, like we have the data right now, and basically the nurse I was referring to before exported everything into Excel, and she has nice pie charts and everything and the whole breakdown. But we're just wondering about the next step and, you know, what to specifically ask of a statistician if we need her, kind of that next step, just to kind of distill the information and bring it to something meaningful for stakeholders and for the people who participated in the survey. We want to get back to them too and tell them what we found. So, I mean, and we were kind of hoping, and just looking at it, you know, the raw data right now, there are some instances where I was like, oh, I was kind of expecting that maybe an RN or a social worker would say that more of what they do could be done by somebody who was non-clinical. And a lot of the social workers did not say that. And I think some of it just speaks to the pride they have in their work and just kind of the people that they are, that they're like, you know, I was needed to do this and I'm really glad I was able to do it. But, you know, some of the results were surprising. Some of them were exactly what we thought. And, you know, it's super across the board. So I'm just wondering what the next step should be in the grand scheme of things.
I can jump in just a little bit too, Rich, and then you can go. I was just thinking, first I would narrow down what your goals are of analyzing the data. Like, is it first, are you trying to look to hire more staff? Are you trying to continue to fund your care coordination program, certain activities, you know, have more family presentation? What is like your goals of like when you did this project? And then breaking that down to say, okay, if it is that you're looking for another nurse, showing all of the stuff that that nurse is doing and how much time she's taking and saying, you know, she works 40 hours a week. This is her spending 70 hours and 40 hours, you know, kind of just showing like how much, of course, I'm just talking about nursing, but everyone right now, like social workers, whatever you're trying to hire, if that's one of the goals, really showing how valuable that time was and really dig deep down to what all the different activities that person was doing and how valued they are in your clinic. That would be one way. And then the other way is, like you said, sometimes it is shocking to see some of those different results, just doing sort of like an internal, you know, review of them, like what you expected as a physician for what you thought of how your practice was working and how the different roles that people were having. And you can analyze that different because your goal wouldn't be that you're hiring more staff through that. You're just trying to see what your perspective was and kind of learning what your staff is doing and how you're all working as a team. But yeah, my first thing would just be narrowing down as a group what your goals are from this project and from the data, and then starting to go from there. Rich, I'll let you jump in.
Yeah, so there's a couple of things here, Annie, and I want to make sure that folks know that, CHOC has really been one of the leaders nationally. They've had a really impressive publication, probably been a couple of years ago, about their care coordination efforts. So, Andy, coming back to the question at hand, one is, building morale. When we brought this, both in our cardiology experience and multiple other clinics, the notion that all of a sudden the billable providers can recognize in a fairly quantifiable fashion how much work is done by non-billable personnel, from administrative support staff to non-billing social workers, et cetera, et cetera. So that was one of the points about building morale and a sense of cohesiveness and shared purpose of the team. The other piece that's really important, and we'll get to this in the July session about our Mother's Day card. Remember, the Academy in this year is all about sustainability. So, what are the messages that came out of your data that you'd want to let the legislative leadership know, that you'd want to let your Medicaid program know, that you might want to be able to sit down with a payer, even a commercial payer, to say, this is what care coordination is, this is who does it, and this is the impact on outcomes, family experience outcomes, as well as utilization. So those are the different ways that I would frame it. And then more tactically, to the extent that you and the team would like some additional time to look at the data, happy to do that as part of our Academy experience. We can either take that offline, or if you and your team are ready, I think we're going to encourage during these office hours, if anybody wanted to share data, we're happy to do a group share. But because I want to make sure that that's not an expectation, it's an offer. So let us know if your team would prefer to do something outside of this session. But bottom line is, I think you've got a bunch of opportunity there, both value optimization and team building.
Okay. Thank you. And do you remember, Rich, at what point you did get the statistician involved to look at your data so you felt like you could talk about it? I mean, because right now there's just so much that I'm just trying to figure out what the most strategic next step would be.
Yeah, so actually pretty early on, because the volume of care period, and then the volume of care coordination in the ambulatory cardiology program at Boston Children's is, the size of an ocean. We actually had the statistician early on looking for trends and patterns. So that so I think that's the short answer. The sooner the statistician lays eyes on it, the better. But consider framing for them, which of those goals. Is it value optimization in a value-based contract arrangement? Is it making sure that everybody's working at the top of their license? Is it to encourage transparency and a sense of shared purpose amongst the team? But yeah, I think if you would like to have the biostatistician do the quick eval and then bring that to us, that's I'm open to that.
Okay, thank you. And back to what Heather was saying, Heather, when you guys did it and you were looking at percentage of time that was used for particular tasks, the only issue, I know you can kind of extrapolate and say, based on this, we could say this on a week basis, but I don't think that everybody logged every single encounter for the whole day. Like, it's really hard to say that anybody was able to do that. I know they had intentions to do that, but there are some areas, because we did this across the whole enterprise, anybody who was involved in care coordination that we knew about, or that was officially, within the umbrella of population health. And certain divisions did a really great job, and certain ones I was like, I know you guys are doing more than that. So that's kind of a struggle too. I don't know if you encountered that.
Yeah,
Or
no,
if
we
you guys were like
definitely,
breathing down the backs of everybody being like, it's time to log. I mean, we did the CCMT day email that you suggested, and they really liked that, but I just can't say that they did every single one, you know?
yes. I feel like in the beginning, we were better about logging every single one. And then there was probably some CCMT fatigue involved. And then that's when we tried to spread it out a little bit more. I think initially I told you in one of the sessions before, we were doing like samples, like 1 week would be a Monday, then the next week we would do it on Tuesday or Wednesday and sort of take a sample of that. As we got more into it and started collecting more data, we did switch to a monthly option. And then eventually, our time was done collecting. But when we were having those CCMT days, we were really trying to pep everybody. So sending emails out, encouraging that, we know that their work is so valued and they're spending time doing the work with the families. And so, that we understand that they're busy, but we made it very accessible in the EMR where they had, I don't know how yours is available now, but we use RedCap also, where there was a link embedded in the EMR. So you could do sort of a quick link where you're typing your note anyways about the encounter. And then you could click on the RedCap survey. And I had done it when I was on the phone with the mom, or something, or I'm literally on the phone and just running right through the survey. And so trying to make it as quick and as accessible as possible, and just lots of encouragement in showing the results to the people that were doing the work too. So not just to like the bigger team, but actually showing your social worker, your administrator, your actual team showing their results after and saying, this is awesome. Like, look at how much work you guys are putting in. Look at all of these, data that you're inputting. This is what it's going towards. We really appreciate you putting all this work in. That's sort of how we did it. And I did feel that there were, of course, we probably missed a couple here and there, but when we really put that amount of work into pepping everybody up, showing them the data, discussing the importance of it, making sure they understood why they were doing this, and it wasn't just for some other research project, that it was really to help them, to help the patients, to help the families. I feel like that was how we were able to be successful.
I wonder if you could make an estimate, anyone who uses it, of how much time it takes a person to log in a day. I'm estimating for people, it's like a 20-minute task. They should block that time on our special days when we're logging. But I wondered if anybody else had a different time estimate for what logging takes.
Yeah, I feel like it depends. I feel like probably if are you saying 20 minutes for all of the encounters for the day? Okay. Yeah, so I feel like it depends on how long you make your CCMT, but I feel like that sounds reasonable, especially for someone doing a full day of care coordination from 9 to 5. There's ways to bulk it too. Everyone's style is different. The way it worked for me was like, as I was actively typing up a note or like actively in the patient's chart, logging it right after that encounter. Some other people might choose to keep like a Word document open or written down like an MRN and the name and what you did. That might be another way. And then at the end of your day, maybe you're just bulk logging them all together. But whatever style works for you, or maybe it's the morning time, then you log it, then you go to lunch. However, people can sort of do what works best for them. But that's kind of what I found. But yeah, I'd be interested how long it takes. I would say around 20 minutes or so, if you're really doing a good job with logging all the details. Rich, would you say anything different for what you've experienced with time?
No, actually, again, I'm sort of putting some stuff in the chat, so there's a little bit of an archive.
Yes, thank you.
I think the only thing that I would add is think about why you're doing this and how long you need to do it. We don't, I don't think I've ever recommended do all your encounters. Cross-sectional sampling to get everybody to the top of their license, so to speak, or their scope of practice. Cross-sectional sampling to show, what's typical in a day for a fill in the blank, community health worker, social worker, administrative support person who is supporting members of the clinical team, et cetera. So be mindful to minimize the burden. As I indicated here, if your instrument takes more than 60 seconds, just 1 minute, it's too long. So you want to trim it back to be able to make it a 1 minute click event, if you will.
And that goes back to some of like not being so super specific and so granular. If you have some of those bigger categories, a couple for each one, so that someone's clicking really quick. It's not like I did this very specific task and they have to go and look and read it. Shorter was better, 1 to 2 words, some of the options, so people can just read through it really quickly. Does anyone else have any other questions or any data that you've already gathered that you want to share or start to talk about? Or if you're in the phase of not knowing, like, have you implemented it, or you're starting to think about it?
We used it we did a sampling period for early in CCA, and our nurse care coordinators scheduled a lot of time as not needing a nurse to do it. And so we're just going to do a resample of that because it was higher than I thought was true. And so we're going to revalidate that with another kind of spot sampling to figure out where they're at now, a half year into more experience as care coordinators.
Is
Anyone else?
Yeah.
Yeah.
Oh, just jumping in. Is any other group using the PICS survey, and has anyone collected data so far from the patient family experience? Right.
So I'll just say really quickly, because Karen, who's on my team for this, is not involved in this particular thing, but we have another venture with a commercial insurer that's they're piloting, having us do some care coordination for their patients who are seen at Chalk Hospital. And for that, we're using the PICS. It's been really hard getting people to complete it, to be honest with you. I think it's a great survey. And maybe if we can get texting, we're working on it. If we can get text to send the link, it might improve it, but we're doing it just through email. And I don't know, I think people are just so overwhelmed with the virtual world right now that they're just like deleting emails or not responding to emails. So I think that's like our biggest barrier. But other than that, when people do fill it out, it's a great tool.
Oh, interesting. Yeah.
I feel like COVID maybe can impact that a bit because it wasn't so virtual, like when this was created too, and starting to use it. But that would be awesome to get a text link, because I do find that even like I had my own physical today, and I was able to, I got a text that said I needed to fill out my COVID pass. And so I was able to click on it right away, all set, was able to walk right in, and my provider already had the information. Starting to be more technical and figuring all that out too.
This issue of the impact of the pandemic on especially children with special health care needs and children with medical complexity, and especially what we know about racial, ethnic, and linguistic and disability factors in terms of inequities. There's a version of the care coordination measurement tool that we've adapted specifically for virtual encounters. And that actually is on the provider side. So I have a CARES award in partnership with the American Academy of Pediatrics, where we're actually looking at the impact of virtual care on care coordination for children and youth with special health care needs. Is anybody or any of the teams doing anything to capture the value of the virtual care that you're doing because of the pandemic? And if so, if you feel free to say it verbally, but I'd love it if you could just put it in the chat, because we would like to do we'd love to be able to do some outreach to you for our AAP sponsored CARES award.
So the teams that are also participating in the CMC CoIIN, we collected, added some telehealth specific or virtual visit specific questions to our parent survey that asked about the value of the visit. And then we also queried our providers about the same thing.
Okay, so I'll have somebody from my team, Rhonda, circle back to
Okay.
you and I don't mind revealing my bias. My bias here is not to demonstrate that virtual care is comparable to face-to-face, but in fact, if there's added value, and we're trying to identify what those criteria are, right? And the early indicators are these: significant behavioral health needs of the patient, travel and access needs, and especially when there's already a pre-established trusting relationship between members of the care team and the family. We're using virtual care, for example, to say, remember that care plan we created 30 days ago? Let's go over that together. And it's forming the basis of a clinical encounter that is specific to care coordination. So again, anybody put in the chat if you're doing something similar to what Rhonda is, and then my team, we will circle back to you. Montana team, I know that you have some focus on Native American communities. You're already on our short list of folks that we're going to be reaching out to. The goal here is to inform the federal government on what the value add contributions are to equity, to value, and to the multidisciplinary care teams.
Yes. So the group from Colorado, because their whole, and so they were doing some value add stuff even before the CoIIN started. So I'll reach out to them to see if they'd be willing to share the data, because there's a little different, little richer.
Okay, thank you.
Does anyone have other questions about PICS or any other data that you're collecting? Like I said, we'll keep this sort of open and non-formal, so feel free to pop on. You can ask any question, or if you're hearing that another team is doing something and you're interested in what they're doing or how they got started, this is now the time to check in with each other. All right, and if no one has any other questions, we'll hang out for a few. We're booked until 6, but Rich, if there's any other way you wanted to drive with the session, I think now is an open time. But otherwise, we'll hang out for a few more minutes. But we're here for your questions about how to analyze your data, how to get started collecting data, you know, what you're doing, what tools you're using, and where you want to go forward. We're here.
This has been really helpful. Even though I've used these before, I mean, they're like practical, like, you know, as I'm writing them down, I'm thinking, duh. I mean, I think of this.
It takes us all to come together and just talk about like going through the process of it too. I learned so much when I was doing it, you know, rather than reading about it and learning it. When I actually started doing it on the ground and seeing the data and talking with people, you know, that's when I learned the most.
Yep, yep. And I know we didn't talk about it this time, but I just want to thank you guys again. The sustainability learning session that we did back in May, finally, I have been struggling with that again for a CoIIN project. And how the heck do I define this? Where do I even begin? But that just really helps so much.
Oh, I love it.
The way that you guys approached it. Oh my gosh. Yes.
Well, Jeff Schiff had jumped off earlier, but he is sort of, he's the brains behind a lot of this stuff too. Rich and Jeff, I can't thank you guys enough. I'm their counterpart trying to put this all together, but their brains have been so powerful.
And, you know, this is a journey that we're all on together, Rhonda. So thank you for your comments. You know, to be fully transparent, we continue to have direct conversations with our federal partners in conjunction with our BU CMC CoIIN partners. But as you know, there are also teams in the academy that aren't part of the CMC CoIIN. So first of all, acknowledging the MCHB gave us the ability to include any willing members of the CoIIN and then some additional teams, number one. Number two, because of that conversation, we're able to engage CMS at the federal level to basically demonstrate to them what are the necessary activities that would trigger consideration of payment sustainability. Mary, you and I go back a long way. I think we were both teenagers, and now that we're both 29 years old, but it's been a while. But I will tell you, it's really great that we're trying really hard through the next waiver here in Massachusetts. We've got 1 year left on the current ACO, but our Medicaid agency has actually said, tell us what care coordination looks like so that our next waiver application will land at CMS. And my goal, again, full transparency, is not to have the Massachusetts waiver just based on, what have you done to Boston Children's? In fact, the more other states that are embedding language in their waiver applications, think about two teams that are in our academy, right? The Inc. team from New Jersey, the Inc. team from North Carolina. I think Ohio has an Inc. Team as well. The more folks that go to CMS talking about care coordination, what is it, how to measure it, and what does it take to pay for it? This is the sustainability. It will not happen in the next year, but I am excited to share that chipping away at this, especially in the space around equity. I keep bringing equity back. It is race, it is ethnicity, it is language, and it's disability status. And so we're going to keep hammering away about measurement, stratification by R, E, L, and D. And CMS is going to hear this from multiple states. So that dynamic is actively at play.
I have a slightly different question, and I wonder if anybody knows or have heard about whether the guidance around the ACE Kids Act is moving. It was due out October of 2020, and it's a little later than that now. Is there any word?
I couldn't understand. Repeat it, Mary.
Sorry. The ACE Kids Act guidance. I don't think it's come out yet. Is that correct?
I haven't seen it either. And in fact, I know what it had been, and I'm hoping that it's going to get meaningfully changed. And so
it was due out in October of 2020, and I don't think it's out yet.
That's right. In fact, I'm glad that I didn't see that version because I know what was going to go into it. So I'm hoping this newer version is actually going to allow this kind of care.
So Mary, I'm so glad you brought that up because I was going to ask about. So I've been told from our state Medicaid folks that it's the state opts into the ACE Kids Act.
That's correct.
Okay. So have you guys heard anything from your states? I'm just curious. Yes, no?
We've been talking with them about it, and they are willing to allow us to propose ideas for it and even do some of the drafting of it. But without the guidance, it's a little hard, right?
Right.
And so, it will be on a tight timeline because it starts in 2022. And
okay.
Consultants tell me it's a year process to 18 months to write these.
Teresa, would you mind speaking a little bit to what you saw and some of the point that you have there? Because, the prior administration had one view of ACE Kids. This one takes a different view of care in general, but I don't know how it's going to translate. So what version did you or your team see, Teresa?
What we had seen was some recommendations that were put forth by a panel of experts. I think they went up in June of 2020.
Yes.
And it had to do with the definition.
Mm-hmm.
And a lot of talk about the use of the chronic conditions classification system as being one of the ways for doing tiering. And so we're very interested in learning more about this classification system. Of course, we've found some of the files out there, but I'm missing protocols about how to actually use those files in a way so that we could figure out. I can give it to the statistician people and they can actually tell us about the numbers of kids that we would be looking at. That was one of them. And then there was a second set that was released. And I'm trying to think specifically about what that was about, but that was, I think was it Meg Como was on that group? I'm trying to think, and that one had to do with really thinking about the metrics that would be used. So, and that was sent in, I think, in November of 2020. So these were documents that were being forwarded up to CMS for the expert panel recommendations. Is that helpful to anybody?
Well, it's helpful in that it's dated, because that's what I had heard as well. But the 2020 timeframe is really important. There are, for those of you that have looked at the core measures for either the child or the adult core set, you'll notice that there really is no presence there at all of relevant quality measures or care coordination activity measures, to be honest with you, that would be relevant for kids with medical complexity, for example. So I think there's a lot of stakeholders that are interested in this work. And this is one of the conversations we're trying to have with CMS as to who are these high resource utilizing children, youth, and young adults, and why, what measures of outcome would be relevant in addition to well-child measures.
Rich, if I can just mention something relative to the ACE Kids Act, this is Steve Fitton. Meg and I did along with Beth Lynn, did a presentation at AMCHIP, and the focus of that was that there are many Medicaid policies that can serve as a vehicle for different kinds of interventions and innovations for children with complex health needs. And we covered them. The AMCHIP recording, I think, is available. And there's a paper that's longer than it should be that will be sent out shortly. And I think we sent out an earlier draft that identifies all these different potential policy instruments. So while I find the ACE Kids Act incredibly encouraging because of the fact that it's, passed federally when nothing else was passing, but with a focus on complex care children, I think it's very encouraging, and that legislation deserves all kinds of focus. But there are other ways to get to where you need to go outside of that. And the fact that it doesn't have an effective date until October of 22, we've been starting to look at 2703 waivers, which are the more generic health home waivers. So there's just a lot of material and a lot of potential and opportunities within the Medicaid policy framework to move forward for this population and for the work that everyone's doing.
Steve, thank you for that. And in fact, I think what you've said is really, really important. And so we should, the core faculty for the Academy should talk about this. What are the other opportunities going forward? The ACE Kids is an important resource, but it's not going to answer everything. So let you and Jeff and Heather and I can work with Meg, and we'll plan a session to talk a little bit about the alignment of these things. That said, I want to make sure that everybody knows your Mother's Day card is still important. That's going to be the value stream for what care coordination is, why is it important, why the chair of your Senate Finance Committee needs to know about it, why Medicaid needs to pay attention, et cetera. So the good news is it's not one or the other. It has to be a multi-pronged approach.
Does anyone have anything else they want to check in about? It doesn't have to be related to CCMT and PICS and data. It can be really anything. All right. Well, if no one has anything else, you can feel free to leave the session. I think Jess will probably hang out until 6 just in case anybody pops in and out. But thank you all so much for your time and for coming today. I hope you enjoyed the first open office hours. We'll discuss forward and we'll see you guys all on July 26th. Nice to see you, Rhonda. Thank you for all of your involvement today.
Thank you everyone for joining.
Steve, bring that point to the next core leadership, because I really like that idea. What are the other tools in this space? So the Mother's Day card needs a place to land. And boy, did I like the way you just framed that. And I think you're talking about the draft manuscript that you sent a week or two ago.
Yes.
Yeah.
And